Multiple sclerosis is a debilitating neurological disorder that is commonly diagnosed in young people. Commonly referred to as MS, MS involves both physical and cognitive deterioration. It is severely disabling for an individual in the future. So, presenting symptoms for MS vary among individuals and they can often be unpredictable. Some of the common symptoms involved with MS include headaches, migraines, numbness, sensory loss, urinary, bowel and sexual dysfunction, fatigue, heat intolerance, balance problems and leg weakness, vision, cognitive and sleeping problems. So there is not one specific test yet to diagnose MS. Diagnosing MS can be difficult for most practitioners due to the sudden and unexplained onset of these symptoms. So it is important to consider and exclude any alternative diagnosis. A number of clinical and paraclinical tests are used to diagnose MS. A diagnosis of MS involves the presence of signs and symptoms and 3 tests: a lumbar puncture, evoked potential studies, and an MRI. So the McDonald criteria is the golden standard practitioners follow in order to diagnose MS. An MRI criteria states that the MRI results need to show dissemination of lesion in space and time. It is expected that there will be 1 or 2 more T2 lesions and at least 2 out of 4 CNS areas. These areas include the periventricular, juxtacortical, infratentorial, and spinal cord. This is commonly referred to as dissemination in space. With dissemination of time, it can be established in one of 2 ways: a new T2 or GD, GD meaning gadolinium enhancing lesion, compared to a previous scan. Secondly, the presence of an asymptomatic lesion and a non-enhancing T2 bright lesion on any one scan must be found. So the neuropathology of MS involves myelin being lost. Oligodendrocytes are the cells that make up myelin, and these cells are lost. So myelin is significant for normal nerve conduction and processes. White matter lesions show inflammation, axonal damage, and gliosis. Recent studies have confirmed that substantial changes in grey matter also contribute to the pathology of MS. So in the early acute activating stage, the lesions are hypercellular due to the many macrophages containing myelin debris and several parenchymal as well as perivascular lymphocytes. As the lesion develops over time, the plaque tends to grow centrifugally, meaning it is growing away from the central nervous system. Plaques become increasingly hypercellular with proliferation of fibrillary astrocytes. Chronic active MS lesions are plaques with inactive centers but hypercellular margins, displaying ongoing demyelination. Further in the disease course, most MS lesions become chronic inactive lesions without any signs of demyelination, little inflammation, but dense fibrogliosis. So a little further on the diagnostic tests that are used for diagnosing MS. So the purpose of a lumbar puncture is to retrieve cerebrospinal fluid for examination. And what is needed to be found in the laboratory tests for someone that has MS, there needs to be a rise in IgG index and show oligoclonal bands. So the pathology behind these results involves inflammation and release of T lymphocytes and macrophages during the demyelination process in MS. So some negative aspects to the lumbar puncture is it's invasive and it may be uncomfortable for the patient. There is no specific biomarker which can confirm the diagnosis of MS. So future research into blood and CSF biomarkers is promising in the field of neuroscience. The next study is evoked potential studies, and this assists in measuring the electrical activity of the brain in response to stimulation of specific sensory nerve pathways. So they basically give a functional reflection of sensory and motor systems. Can detect the reduced electrical conduction caused by demyelination in MS. Visual evoked potential studies can detect lesional spatial dissemination. During the course of MS, evoked potential studies can be used to confirm unclear relapses expressing vague symptoms, and it's also good in demonstrating drug efficacy. So there are 3 types of evoked potential tests. These are visual evoked potentials, brainstem auditory evoked potentials, and sensory evoked potentials. Unlike MRI, it is not specific in showing the location of the lesion. The last and often the most highly regarded test in diagnosing MS is the MRI. So it's really good in identifying the time of an incident attack and the chronic nature of the disease. Although lesions may be found that are unrelated to MS and may be pre-existing, so it cannot be solely used in diagnosing MS. Even with the results from this test, within the McDonald's criteria, it states that the diagnosis of MS is dependent on the evolution of neurological symptoms and signs. Some of the negative aspects of MS include the exposure to radiation, and there are some concerns in regards to safety that surrounds the repeated exposure to gadolinium-based contrast agents, which patients must consume prior to the MRI. So many diseases share similar signs and symptoms to MS, and some of these conditions include Lyme disease, lupus, and stroke.